So with that, we're going to get started. I just want to remind the presenters that there's approximately 5 minutes to present your case and 5 minutes for questions, okay? So our first speaker today is Dr. Antonio Emmanuel Recto, presenting true or false star technique to bail out a stented LED false lumen. So welcome.
Okay, good morning, everyone. I am Dr. Antonio Recto from the Medical City in the Philippines. I am here to present this challenging case entitled True or False? Star Technique to Bail Out a Stented LED False Lumen. I have no disclosures. Ooh, it's not working. There. I have no disclosures. Sorry. So we have a 60-year-old female who presented with angina and was being managed as NSTEMI. She has been hypertensive for 5 years on medication but no BP monitoring. The angina started 3 weeks prior but with negative troponin levels. It recurred 1 day prior with 10/10 severity. The physical examination was unremarkable. Here's the ECG on admission with a heart rate of 92 beats per minute, sinus, regular rhythm, and a possible septal infarct indicated by the Q wave in lead V2. The coronary angiogram showed the left main as a 4O vessel with no significant disease, and the LAD is a 3-5 type 3 vessel with a 90% proximal and 70% mid-segment stenosis. The first diagonal branch is a 2O vessel with a 70% osteoproximal stenosis. The LCX and RCA have luminal irregularities with no significant lesions. The initial IVUS run showed mixed fibrocalcific plaque with a DRA of 3.72, MLA of 2.8, and PRA of 8.94 millimeters squared. After wiring, we did pre-dilation of both the D1 and LAD prior to planned drug-coated ballooning of the osteoproximal D1, then stenting of the proximal to mid-LAD. Seemed fairly easy from this point. After using an Agent 2O/15 DCB on the osteoproximal D1, the cyan blue wire of the LAD was inadvertently pulled out and quickly redistalized. Repeat angiography revealed no reflow at the mid to distal segment of the LAD. We immediately stented the proximal to mid-LAD using a Synergy 2.5/48 stent. Several post-dilations were done at the distal segment, but there was no resolution of the no reflow. Intracoronary NTG, adenosine, nicardipine, and tirofiban were administered, but still no improvement. An export advanced aspiration catheter was also used, but no thrombi were aspirated. A second Synergy 2.5/12 stent was deployed at the mid to distal segment, followed by several post-dilations. Despite all our efforts, there was no restoration of flow. We were asking each other what caused the acute vessel closure. We did the repeat IVUS run and realized that the inadvertent rewiring of the LAD caused a type F subintimal dissection all the way to the distal segment, and we made it worse by mistakenly stenting the false lumen and compressing the true lumen as seen on the photos on the right. At this point, we realized that the only way to restore flow into the distal segment was to re-enter the true lumen. With IVUS guidance, we attempted a star technique using an Asahi Conquest Pro, Gaia First, Conquest Pro 12, and Gladius wires through an Asahi Caravelle microcatheter, which all initially failed. We also used the Caravelle for false lumen decompression. An Asahi Gaia Third successfully penetrated the true lumen distal to the stented area, and luckily distalized into a septal branch. Unfortunately, attempts to distalize a wire further through the collapsed true lumen at the area of the septal branch ostrum failed with an Asahi XTR, Fielder XTR, Gaia Next, and Gaia Next 2 through a Sasuke microcatheter. This part of the procedure was not fluorosaved, so allow me to use this diagram to explain what we did next. With the wire secured in the septal branch, we used a Sapphire 1, 10, 15, and an Emerge 2O balloon to dilate the septal ostrum to expand the true lumen in that area. This technique offered enough true lumen space for another cyan wire to distalize into a second septal branch through a Sasuke microcatheter, while another cyan blue finally distalized into the apical LAD. Another IVUS run through the apical LAD wire confirmed that we were finally within the true lumen, thanks to some septal branches that helped along the way. We were able to dilate the distal LAD with a Sapphire 10 and Emerge 2.5 balloons before deploying a Synergy 2.75/20 stent. After 6 hours, angiography revealed TIMI-3 flow across a continuity between the mid-LED false lumen stent and the distal LED true lumen stent, which restored antegrade flow and recanalization of the apical, septal, and diagonal branches. A final IVUS run showed a minimal stented area 4.66 at the distal segment, a stented mid-segment with a patent false lumen and a collapsed true lumen, and an adequate stent expansion and strut apposition with no dissections or perforations. Final post-PCI angiography showed side branch loss of 2 to 3 minor septals and 1 small diagonal at the mid-LAD, but with good flow along the distal and apical LAD and its branches. I end this presentation with some key learning points in managing this complication. It is important to immediately and meticulously confirm wire position in the true lumen via IVUS if inadvertently pulled out and redistalized. IVUS guidance, wire escalation, and microcatheter utilization are crucial in maximizing star technique effectiveness. And septal branches may be utilized as a guide and space to further distalize the true lumen. So thank you for your kind attention.
Fantastic case. That was a fantastic case presentation.
Thank you very much.
Great technique there. A couple of questions for you, and then we'll ask the panel. Obviously, when you lost the wire first time round, that was the issue.
Yes.
With hindsight, were there any lessons? Did you use the wrong wire? Was the feel different in the false lumen?
When we rewired, we did it very quickly. We didn't notice any resistance, but we did notice that the wire did buckle. And maybe that was a significant enough sign that maybe we weren't in the true lumen and we actually caused a dissection. But at that point, it was fairly quick. And then after rewiring, only then when we did a repeat angiography did we see that there was no reflow. And yes, in hindsight, I think one of the mistakes we did was we actually did an IVUS run earlier to confirm that wire position, but that initial IVUS run after the dissection, we didn't notice the dissection at first. We were like, okay, it seems like the stent was okay. We didn't notice that little area there that seemed like it was a collapsed true lumen. So in hindsight, we should have been more meticulous with that.
Don't criticize yourself. It was a great pickup. One final question, then I'll hand over. Did you consider looking at the right coronary artery to see if there were retrograde filling, maybe interventional, non-interventional collaterals from the right once you'd lost the LAD?
Thank you for that question. Unfortunately, no, we weren't thinking. We only had one access, the right radial, and we only had the one catheter in the left system. So at that point, we weren't concerned about doing another access and trying to check the right coronary.
Just a quick question. So your comments on using this STAR technique here, seems like you might have used a combination of re-entry techniques, really, because initially you were sort of using IVUS guidance to try to puncture with stiffer wires, I guess, and then once you got the dual lumen catheter involved, then you went down to more softer polymer jacket, and is that what ultimately re-entered? Is that correct?
Yes, definitely. Well, when I say STAR, it's technically a modified STAR because we didn't re-enter, and I'm sorry, we didn't enter a dissected area and then re-enter. It was more of entering the true lumen and then making sure that we were still in there. So what we did was with the diagrams, since we were able to distalize into a septal branch, we knew that there was some space in there that we knew that we were in the true lumen. So we tried to dilate that area a little bit with a small balloon, 1.0 and a 1.5 in that ostrum of that septal, and hopefully with the double lumen Sasuke microcatheter, we were able to maneuver a soft wire into the true lumen and distalize it.
Thank you. Any comments from our panel on approaches to these situations where you've lost flow in the distal vessel that you're working on?
So once again, thanks for sharing this complication and good save with that. So I think always remember that when we don't see flow in the distal vessel, to go through your algorithm. Yes, it could be no reflow, but dissection is always at the back of your mind. So good catch, and for maintaining your composure, that is very important. Because like you said, 6-hour case. Yeah. So.
It should have been less than an hour, but.
Well, but at the end of the day, you restored
Yes.
flow to the majority
Yes,
of the
definitely.
branches, only lost that one small diagonal that you had mentioned. Of course, we worry about that when starring in the LAD. But I think it highlights the importance, too, of using the CTO or the complex coronary techniques in non-CTO cases to
Yes.
reduce point with getting retrograde access potentially and seeing if you could have gone through some septals that are now uncovered. Of course, you got a great result at the end of the day. Work through the algorithm with intracoronary medications and thrombectomy, et cetera. And then also potentially an opportunity when you're going to rewire what you've pulled the wire for a dissection using a very soft wire like a suo that's not going to extend the
Yes.
dissection. Once you get into that false lumen, you said you felt some resistance there as you were pushing your wire back down. So once the wire is out, potentially an opportunity for learning and teaching, but a great save, and I'm sure the patient's doing well now.
Thank you for your comments, sir.
Excellent. Thank you very much. I think we're going to move on to the next
Thank
case.
you. Thank you, everyone.
So our next presenter is Dr. Ahmed Elborae, and they're presenting on All Roads Lead to Rome.
Okay, thank you. Good morning, everyone. One said that all roads lead to Rome, and today we will discover one of these routes. Our patient is a 57-year-old lady, status post mitral valve replacement twice. Last one is on top of severe paravalvular leak. Presenting to us with shortness of breath at moderate exertion and severe hemolysis that necessitating repeated blood transfusion. Here is her echocardiogram, showed dilated LV dimension with preserved function, hugely dilated left atrium with significant mitral paravalvular leak at the anterolateral side at almost 10 o'clock. So, what you doing here in the coronary session, we'll discover together. Actually, this patient has challenging transseptal puncture. We opted for a higher posterior one to be more aligned with the anterolateral defect. But the puncture is challenging even with TE guidance. So we did something off-label. We used it before in some cases, which is doing the transseptal puncture using a CB12 CTO wire. And here is all thing started. The wire take a funny course, so we opted for transseptal needle injection, and here is what we got. Oh my God. It took us about few seconds to recognize what we are dealing with. We have some sort of fistulous communication through the septum into the left main coronary artery. And what we see on the right side is almost a hematoma or a false lumen in the left main and compressing almost the LAD. So surgeon was notified at this time, and we have already their femoral axis used for snaring the retrograde for the BVL closure procedure. So we introduced GL for guiding caster, and then passed a cyan blue wire into the LAD and circumflex. And then we did IVUS imaging, which showed a very large intramural hematoma compressing the lumen of the LAD and also compressing the lumen of the left main. So we decided upon this picture to do PCI to left main LAD to decompress this hematoma. This was done using a 4O stent, followed by both using a 5O stent. We used a guideliner for injection to minimize the inadvertent flow into the false lumen during adjusting the stent. At this moment, we have a discussion with the surgeon, should we stop at this moment or we can proceed. The patient was hemodynamically stable, no pericardial effusion, so we thought that we mostly went through a transection in the septum rather than perforating the atrium itself. So this time we did the puncture using steerable sheath Agilis 1, and it went successfully. Then closure the defect using AVP3 device 10x5, and there is the final result. We'll seal the defect with no residual BVL, and fortunately the patient is discharged home safely after 48 hours. So learning points from this case, imaging, TE or ICE is progressively becoming the standard of care for transseptal puncture. Electrocautery or radiofrequency facilitated transseptal puncture in tough cases should be preferred rather than off-label solutions that we used in this case. And finally, coronary training is essential, even in structural program, to be able to deal with potential complication. And there is a title of our case, or also lead to Rome, how this wire find its way to the left main. Mostly transected the intra-atrial septum through the roof of the aorta, then into the left main roof. And there is thanks from our team at Aswan Heart Center. Thank you.
It's a brave case and a even braver save, I guess. What did you guys, did you advance a microcatheter over this wire or the CP wire, or was it just the wire itself?
It was advanced through the transseptal needle lumen itself. But the behavior of this wire is totally unpredicted. So I don't advise, or we did it again.
So the initial transeptal, you couldn't traverse or go through the septum with your regular needle?
Yes, it is almost keep sliding due to the huge left atrium. But at the second time, we used the steerable Achilles sheath. This facilitated our job, and it was a simple one. So if we back to a few moments before this catastrophe, we should do this from the start and not to use CP12.
I mean, just for most of us in the audience, can you go back to, can you take you back to the slide and just walk us through that angiographic anatomy, the injection through the transseptal needle?
Okay.
Yeah, I mean, as you're doing that, I agree the CP12 is going to go somewhere. You know, a tapered, stiff, gram-weighted tip. And so I would, you know, obviously that contributed to this because it doesn't confirm you're in the right place. But I think when you have that gut feeling that it's not going the right place, you should always heed that emotional feeling like you did here.
So what we see here is fistulous communication between the left atrium septum itself. The tract was intramural inside the wall of atrium, then through the wall of the aorta, ending by opening into the left main. What we see here is not the left main itself. It is mostly the large hematoma, and it finds a way or another into the circumflex. But the LED is not clearly visualized here because it was compressed almost totally by the hematoma.
I think it's very important too, your use of intracoronary imaging. Once you did get wires down, you're able to really nicely confirm your wire position in the true lumen before you did anything further, and to understand that hematoma presence for sure.
Because when I searched for such a complication, this is the first time reported such complication.
I was just going to say that's a great picture of the pressurization of the intramural hematoma there. You can see that as the contrast darkens, that it's just filling that intramural space and compressing. That's a great picture. Yes. Not emotionally, though.
Well, then also on the IVUS run, if you go forward to that, you can see the dynamic compression of the coronary as well, which is horrific but great. So, you know, just to have that picture right next to one another. The initial puncture was with a standard needle, not an RF needle. The attempt that kept sliding was a standard needle, Brockenbrow?
Yes,
Okay.
we did it multiple times, but it keeps sliding. The patient has huge left atrium.
So do you think had you used RF, that would have been more successful, or obviously you're not going to do this again for obvious reasons?
No, we will use the one that succeeded, which is using steerable sheath or radio frequency facilitated puncture, but we'll never do it again.
I think the catheter, I mean, although in a coronary tract, but I think a catheter that has a different shape that will pin the septum with a high left atrial pressure was the key, and that's why you use the Achilles, which is steerable, gave you the ability to really tent and then perform some pressure so that you can go through the septum is the key.
Yes.
You know, and you're very fortunate too. If you look, you know, you have the left main is your distal fenestration here with that injection. And so clearly, you know, thank God you're able to engage that into the true lumen and wire the true lumen there, because you could have very easily, you know, put in a guide in there and gotten into the false channel.
Fortunately, we managed to go to the true lumen, but as you said, that's just by luck.
It's interesting too, in retrospect, you know, you understand that maybe the injection itself made the hematoma worse, of course, but you couldn't have predicted that that's where you were going to be before you injected this time. Okay. All right. Well, thank you for that, and we'll move on to our next speaker.
Thank you.
Okay, so we'll move on to the next speaker, Dr. Sandeep Jalli on externalization. Yeah,
I actually have a question about the last case as well. So before you guys crossed with your transseptal system, did you not look for the wire in the left atrium? So you don't think you're going to see it at all? Got it. Okay. Got it.
I was also curious what your surgeon said when they showed up to the room. I didn't hear that aspect of it. On the third time, redo mitral from 20 years ago. What choice words were used?
All right, perfect. So the title of the talk. All right, so the title of the talk kind of gives it away, unfortunately, but pretend you didn't see that. I have no disclosures. So this is a 78-year-old male with a history of bypass, lima to the LAD, vein to the OM, and vein to the PDA. Had a previous history of RCA, CTO, PCI like 2 years ago. It was a really complicated procedure. He arrested during it, almost ended up on ECMO. And has had multiple admissions for acute coronary syndromes. Before the case that I'm going to show you, we had attempted native circumflex CTO PCI on him due to a failing vein to the OM. We ended up aborting that procedure because he developed acute heart failure during the attempt and stented the vein graft. So this is one of those people, you know, you sort of recognize names when you get the call and they pop up on your list. This is one of those, and he came in again with acute coronary syndrome and chest pain. My first thought was, God, it's that stupid vein graft again. But thankfully, the vein graft was okay. He had a normal EF, actually, on echo. This are the angios from his CTO PCI. Again, that was a pretty long and complicated procedure. So you can see that they got a good result, but the distal PDA, sort of where the vein graft touches down, does look funny. Patient was doing okay, so they left it, and he actually did okay like that for a while. And this is the current angio. It's the left coronary system. There you can see that there's a not very helpfully placed left atrial appendage device, and that's angio of the right. Most of the right looks okay. There's a lesion in the PL, and then the PDA, sort of where the graft touches down, really does look really weird. So we decided to give this a try. We did a right heart cath first, given all the hemodynamic issues he'd had in the past. His filling pressures were actually really good, had a good index and a wedge of 18, so we decided to proceed with PCI of the PDA. For some reason, I decided to stent the PL first, and I put a 2.5 millimeter drug-eluting stent in there that looked fine. Maybe like trying to hold off the emotional trauma of this for a while. Used a turnpike, tried with a Cion Black, didn't really go anywhere, wasn't successful. Did pretty much everything else we could think of in the algorithm. We used a dual lumen microcatheter. We tried to reverse wire it. We used an angulated microcatheter. Used every wire we had, Cion Black, Gaia Next. Weren't really going anywhere, but we could interestingly get into sort of the stump of the old vein graft, which thankfully they had not coiled. So the challenge here is that we're unable to wire past this vein graft touchdown into the distal PDA antegrade. As the title suggests, we ended up externalizing, so we were able to get a Mongo and a microcatheter up pretty easily, and got the Mongo actually out into the aorta and the microcatheter up more. Switched out for an R350 that we spent, I think, must have been the longest snaring of my life, getting that R350 out, but eventually got it out. And at this point, you know, you've made sort of overcome one hurdle and you think you're getting to the end, but of course we're nowhere close. So now we used a dual lumen over the externalized wire, put a cyan black into the PDA, which sort of has us around 50% solved with our problem, because now we have access to the distal PDA, but it's through a vein graft that's already failed once before, so we don't really want to keep this. We did kissing balloons, both antegrade and over the externalized system, to try and make some space there. And this time we were successful reverse wiring antegrade, and were able to get a cyan black down into the distal PDA. We advanced a turnpike antegrade over that wire, switched it out for a wiggle, ballooned it, and put a 2518 drug-eluting stent over that sort of tented anastomosis. Decayed the PDA and PL. And this is the final picture. I think the learning points for me were that externalization can be useful, even in non-CTO PCI. Reverse wiring is a really essential skill to have, and it can really help you out. And, you know, sometimes things go better than expected.
How about some comments from the panel here? We'll start at that end.
Yeah, great case. I think knowing what you have in your toolbox and just thinking about different ways, and honestly, you know, we have a saying in our cath lab, you know, vein grafts, in addition to them being patent, they're also useful to be used as conduits down the line. So you've nicely shown that you can use it and use that for support and come down. And so you've done everything. You know, revascularizing both vessels is important. The distal bed is important to be revascularized. Otherwise, you know, you can have a beautiful proximal mid RCA, but beautiful results.
Thank you.
No, I mean, I'll just echo what Kareem said with regards to, at the end of the day, getting a good result, improving outcomes for the patient. Hopefully when they pop up on the list in the future, it's for good follow-ups and you don't curse their name as much the next time they come back. But, you know, solving the issues with the tools you have. And again, another case where you use CTO techniques for patients that, you know, potentially we wouldn't think to use otherwise. So no other comments.
Thankfully, it's Nick's problem now.
Did you ever have a chance to maybe do IVUS guided penetration? Was that part of your workflow initially?
So nothing would get down there. That's the problem. We couldn't get even enough purchase with the wire at that anastomotic site to really get anything to see. We obviously IVUSed afterwards, but yeah.
You know, I'm one of those guys. You know, there's this two camps of SVGs and coiling, and I'm the no coil camp. I'm just so glad you have this case to show why that can come from.
Yeah.
I just have a quick question and a comment. So the previous CTO attempt, was it a star by any chance that they left him with?
No, it wasn't a star.
Okay,
I think.
so it was stented.
Yeah, it was stented. It was stented.
I
They just
see.
didn't stent up to that.
That
And
point,
then-
okay. Yeah,
I
it
think
did have a
was-
funny
I
looking
think it was-
appearance.
Yeah, I think it was in that peri-arrest. They were good enough is good enough.
Got it, okay.
Yeah.
And just a comment that the skill of learning how to do reverse wiring is really important. It can be cumbersome at first, and if you don't practice it, it can be hard to do it in an acute situation, but it's such a good tool, so make sure you get an opportunity to go try it out on models with a dual lumen microcatheter, typically Sasuke or your favorite dual lumen, and often a cyan black is a good wire to use for it, and it can really save the day in certain instances, so thank you.
So which vessel did you use as a side branch when you were reverse wiring? Can you show us the...
Yeah, I'll go back. If it'll go back.
And then, Dr. Hall, I'm curious what your comment is. You know, these are pretty complex CTO techniques, and, you know, when you're in a CTO program, you need to do quite a few of these. I mean, the whole idea of externalizing, coming retrograde through a graft. I mean, would you want a person who rarely does that to sort of try and get skilled at that type of skill set? To me, I feel like even when you're doing a decent volume, you know, we have a CTO program, it's just a difficult procedure to keep track of. So I hesitate to sort of advocate for regular coronary operators to learn how to retrograde and externalize and capture.
Yeah, so I think you can look at that in a couple of different ways. I think one thing that's very important is if you do have individuals at your center who have that CTO PCI skill set, to have a good rapport with them and hopefully have them available in times when you may need their help with something like this. You know, in an acute case, you don't necessarily want to be doing your first wire externalization. So if you're inexperienced with it, but you think it's a technique that would be helpful, then give your good friend, the CTO operator, a shout, and they'll hopefully come by to help you out. Or if it's an elective case, you may be able to rebook it with their help, and you can co-scrub. But in order to get experience with it, you're absolutely right. You're going to need to either take on a personal learning journey, or maybe, again, go and do some co-scrubbing to get some basic CTO techniques in your armamentarium. But it's very difficult to try them for the first time in an acute case.
Sandeep, fantastic. Mark of an expert is the person who hits the fluoro save after a good move. So clearly you're the expert. So I think it's been a wonderful case. Thank you for your time. Thank you. So next up we have Kunal Mishra, who's going to present a coronary conundrum.
You can go ahead and get started. I can get started? Okay. Hello, everyone. My name is Kunal Mishra. I'm a third-year cardiology fellow at Virginia Mason Franciscan Health, and wanted to thank CVI for the opportunity to present this case titled A Coronary Conundrum, and you'll see why it's titled that way shortly. I have no disclosures. So we begin with a 68-year-old male who presented to the ED with severe chest pain. This patient was found to have a NSTEMI. He had classic CAD risk factors of hypertension, diabetes, and hyperlipidemia. He started on aspirin and low molecular weight heparin and taken to the cath lab for a coronary angiogram. So as you'll see here on the coronary angiogram on figure 1 on your right, he had some non-obstructive disease in the left main LAD and left circumflex. I want to direct your attention to the left circumflex particularly, as you'll see some aneurysmal changes in the left circumflex, which may give you a hint as to what's coming. Furthermore, there was collateral flow noted to the distal RCA, which again kind of raised a red flag to what could be coming here. And this is a better picture here in figure 2 showing that circ, showing the aneurysmal lesion that you see there in that circ. So here we have the RCA, and this is in the setting of an ACS event. And note the Shepherd's crook anatomical variant at that prox RCA. So the catheter that we're using here is a Jalli that we use to engage. So initially we thought, hey, is this RCA occluded at the prox to mid? Like, is this the culprit lesion? But in reality, when we thought about it a bit more, it could have been that due to how aneurysmal the RCA was, we just weren't feeling it enough. We just weren't engaging it enough to truly visualize the occlusion. That kind of demonstrates the fact that you really want to visualize where the obstruction is before acting instead of just going at your first shot. So what do? We switched out the Jalli for 6 French AL1, and we actually had to use a microcatheter to allow the AL1 to advance toward the mid portion of the vessel, and this allowed us to visualize the vessel even better. And then what that showed is that not only was the RCA aneurysmal in the prox to mid, but it was also aneurysmal in the distal, and the true occlusion was actually in the distal RCA, as demonstrated in figure 4. So this, again, demonstrates the need for picking the right catheter, making sure we're filling the selected vessel properly and before acting. So we first tried to pass the stenosis with Cyan black, then a Cyan blue. Cyan blue first, I'm sorry, then Cyan black, and then eventually we were able to pre-dilate it, and then we got an IVUS catheter through there, and this is what we found. A ton of thrombus, essentially. Figure 5 and figure 6 show, figure 5 on the left shows an IVUS run through of the distal RCA with that thrombotic occlusion in the aneurysmal vessel. And so you'll notice that the minimal luminal diameter of the RCA being about 2, but the aneurysmal diameter being about 7, with that RCA thrombus occupying all of that. So once we saw this, we noted we were dealing with an occlusion that was noted in the distal vessel, but we couldn't identify where the origin of the PDA was. That was a key problem for us, because if we chose to stent it, we could run the risk of stenting over the PDA, and that would not be a good idea. And so not only that, we went radial access. So we didn't have dual catheters at the time. Recall that we had collaterals from the left to the right. So if we had gone femoral access, we could have done dual catheters and able to visualize the PDA via those collaterals. So that was something to think about as well. But the key point being, there's no real standardized guidelines on the management of coronary artery aneurysm thrombosis presenting as ACS. I think I've listed here two reviews that we were reading at the time as to see if there's something to do, and it really highlights a lack of consensus in literature about how we go about treating these patients. So for just to run it by again, that PCI of the aneurysmal culprit vessel, especially an aneurysmal vessel that's diameter is higher than what our stents can go. In our facility, we have Synergy and Onyx, both of which don't reach that 7 caliber, and they'll lose their structural integrity at that point. And so PCI of these kind of vessels would be associated with a low success rate and increased stent thrombosis. So our options were a couple things. Number one, we could consider going femoral, do the dual injection catheter and try to take it back that way. We could consider thrombectomy without the thrombosis, but the problem with that was, given how distal the thrombus was in the distal RCA, getting a thrombectomy catheter all the way down there would be very difficult. And so that would be one. The other option would be stenting, but we already went over why that would be a problem. And the other option was doing balloon angioplasty and then anticoagulation from there on. And that's kind of, when we discussed this case with our all interventional cardiologists, we all thought that that was the safest option. So patient subsequently underwent balloon angioplasty with the distal RCA with restoration of flow to the RPL, as seen in figure 7 here. It was a 3x30 balloon that we ended up using to dilate that area. But again, we didn't reestablish flow to the PDA. This was kind of where we left it at the time. Our thought was that we gave IC-Tiferiban, we started the patient on Rivaroxaban and Plavix, and our thought was that to bring them back for another angiogram in about 2 to 3 weeks to see, once they're outside of this acute phase, to see if that PDA needs to be acted on and what we can do from that standpoint. So this is the angiogram that we have. Sorry, this is the post-angiogram of balloon angioplasty. This view highlights the thrombus that you'll see there in that distal RPL. So this is the angiogram that we have that was done just about 3 weeks after that initial. And this is after being on 3 weeks of Rivaroxaban and Plavix. And that it shows that not only did the anticoagulation keep the initial lesion open, but we also aided in resolving that PDA lesion. So now we see restoration of flow in the PDA and patient doing a lot better. Now this case was done about a year ago, and so we kept the patient on anticoagulation for about a year. Now there's no guidelines on how long to keep these patients on anticoagulation. In literature, the only study that focuses on anticoagulation for coronary artery aneurysm thrombosis is in patients with Kawasaki's disease. And those patients, when they have thrombosis, the study that I included here speaks to keeping these patients on Coumadin. And so that was the only literature we had to base it off of, but we chose a NOAC in this case. And after about a year and a half, we took the patient off Xarelto, so the patient's just on an antiplatelet at this stage. So just to highlight the learning, the treatment options for these kind of patients, the treatment options for these kind of patients are what we did with angioplasty and anticoagulation. There are options with drug-eluting stenting versus stenting with a covered stent, and the latter would be used to treat the aneurysmal portion. But with our concern was the stenting over the PDA origin. The other question that this case poses is how long do we leave these patients on anticoagulation? Most evidence that I found when I was doing the digging for this case is anecdotal, derived from small case series beyond that Kawasaki's paper that I showed you guys. So what are the key learnings for this case? Well, number one, again, always to fully define the anatomy before committing to intervention, especially in aneurysm cases where the filling may not be complete, like in our case, especially with that shepherd's crook. I was kind of dealing with a perfect storm when dealing with this. The other thing is always consider alternative therapies beyond stenting. Just because it's an ACS event with an NSTEMI, stenting isn't an automatic thing. We have to consider all possible options. And then recognize that anticoagulation in these patients can be effective in selected cases in the acute setting for an ACS-like event. So I open the floor to discussion. I'm curious to hear the panel's thoughts on treating these kind of patients. What would you do different if you would have used a covered stent, if you would used just try to get the thrombectomy catheter down there? I'm curious to hear what you guys have to say. Thank you.
Thank you so much for that presentation. It's a wonderful case. I must say I really like the amount of thought that went into how to manage this patient. You had a very thoughtful approach, which was quite helpful here, rather than just doing a lot of quick actions that may have led to a worse outcome. Before we get some thoughts on the panel on how they'd approach this, I just want to ask about how the patient was doing by the time of follow-up, and were they asymptomatic, and also was there much of an infarct in that territory on echo?
The EF on echo did not show any kind of drop in EF. The EF was like 65%. The patient was asymptomatic post, doing a lot better, thankfully. Even in that 1 month post when they came in for their cath, doing tremendously better. So from that standpoint, we're all quite happy with their recovery.
Thank you. Any thoughts from the panel on how you would manage this case or cases like this?
So we've had a few instances similar to this. Always seems to be a Cabral graft, so a 10 millimeter graft to the left main that thromboses, and then you have a 3 millimeter outflow. A little bit of a different situation, but also similar to large ectatic vein grafts as well. One thing that's been successful for us, and again, in a very evidence-free zone because nobody has studied this and you can't randomize patients, but is to place the patient on a 2B3A for 24 to 48 hours, let that thrombus resolve, and then bring them back, as long as they're doing well, not in cardiogenic shock. The worst thing you could do is put that 2.5 stent in a 7.0 vessel. You then get very late, very incomplete stent apposition, making it very difficult in the future, or putting in a covered stent, as you had mentioned, and losing that PDA access. Dual access if needed in the future. Of course, the left radial is also an option. Don't have to go groin. Groins are gross. You do have a lot of options in the future, but as Allison said, not rushing in, just throwing in stents, and you preserve those options for the patient. Sounds like they're doing well, and the thrombus is the problem for this patient, not necessarily atherosclerosis.
I think the best thing you guys did, and well thought out case, I would say that this, in a way, angiographically seems like, oh, this is just but thrombus and aneurysm is a massive problem. And we see this kind of patients all the time. So best thing you did, in my opinion, is that you did not put in a stent. I think that is the wisest decision, and we should always persist with that. And even if there is no flow, do not put in a stent, because as you was shown in your case, there is spontaneous flow restoration eventually. I'm a little confused about the thrombectomy part of it. What did you say? Did you guys not do it because
of how difficult it would be to get the thrombectomy catheter down there, essentially with the bulky equipment, because of how distal the clot was. I think at that time we didn't think that it would be feasible because it was difficult to even getting the catheters up there. That shepherd's crook made it very difficult for us to even pass anything.
You're not able to get a guideline or
we had we were all on 6 French system. We could have. I think that was something that we thought about upgrading and going that way. But at the end of the day, we favored angioplasty and anticoagulation instead. And if they came back again, then that could have been something to consider.
Even in that situation, the CAT-RX is only 2 millimeters in diameter. So in that situation, the mechanical thrombectomy catheter is 2 millimeters. You're creating a core out of the middle. You could exchange for a wiggle wire in order to increase that surface area, but you're still going to have a huge vessel and trying to remove it. And having done that in a Cabral, and I was like, well, that was worthless. So, but yeah, just the thrombus is the problem.
So, sometimes it's actually a blessing that you did not achieve some sort of flow and left it up to medicines, because you may get fooled sometimes and get some flow. Well, let me then balloon, and then you start showering things down, and then actually completing the infarct, and then you put in a stent, but the flow is TIMI 1 to TIMI 2, and you start putting meds. So we've converted to that. Patient is chest pain free, yes, troponemia is there. Put them 2 days on 2B3A, and then bring him back. And it is interesting to see what pharma does, and it just makes your job much more easier. You're able to visualize the vessels and potentially avoid that idea of showering down things and causing microvascular occlusion.
Do you guys put like the filter wire ahead of that to catch the showering, or in your practice, or no? Not really. Okay. All right. Well, thank you so much.
Okay, thank you very much. Okay, so unless, Rajiv, you tell me anything different, I think the next one is the NSTEMI case, is that correct? Okay, so we'll welcome Dr. David Fernandez Vazquez to present on NSTEMI with PCI when less is more. Okay, go ahead.
Okay, thanks for the presentation. I'm David Fernandez. I'm a clinical cardiologist from Spain. Working on a small hospital in a city called Lorca. We don't have a cath lab in my facility, so our referral center is in Murcia, 1 hour away. My only disclosure is I'm extremely grateful to be presenting here today with such complex cases that we've seen before. This is a pretty straightforward case, 42-year-old male, fit that comes to the emergency department with chest pain. He has a history of being an active smoker, 5 to 10 cigarettes a day, and a family history of protein S deficiency, but he previously denied having the test done, so we don't know if he had the protein S deficiency or not. He was playing soccer, one of those 24-hour tournaments where they play several games a day. So after the third game, he started having ongoing chest pain related to the jaw on the left arm, so he decided to go to the emergency department. And the first determination, troponins were elevated. The normal AKG, and that's the troponin curve. So the patient was hospitalized in the ICU as a non-STEMI. That's the echo that was performed in the ICU, normal LVEF with a slight hypokinesia of the basal septum. And the day after, he was transferred to the cath lab. What they found as normal coronary arteries. So we have Minoka here. Fasting guideline says in these cases that we have to do further tests to assess what can be the cause. So what our colleague did was OCT. We saw there that there's a healthy distal vessel, but there's white thrombus followed by red fresh thrombus on the mid-LAD. So then the scenarios, the option that he had at the moment was either go for full attack, thrombus aspiration, put the patient on anticoagulation, and then deploy a stent, or take a more conservative approach with just anticoagulation and see if that's resolved. So, knowing the title, no surprise to no one, he did watchful waiting, administered tirofiban, and then the patient was placed on enoxaparin and double antiplatelet therapy for 1 week. And then after 1 week, the angiography was repeated and the OCT too, seeing a full resolution of the thrombus with a plaque there in the mid-LAD with intima media thickening and slightly intraplaque hemorrhage, but not complication. So there comes what to do with the long-term antithrombotic strategy. We have a patient with non-obstructive CAD with a LAD thrombus and a family history of protein S deficiency, but this disease is known to produce thrombus in the veins, not in the arteries. Very few cases reported in literature that can be produce arterial thrombosis. And regarding his cardiovascular risk factor, he's an active smoker, not very smoker, but he had a remarkable lipid panel with negative lipoprotein. So the decision was to put the patient on anticoagulation for 3 to 6 months until deciding what happened with the thrombophilia. So since he had already been 1 week with triple therapy, at discharge, he was just with double therapy, clopidogrel and acetylcholinesterol, which is the vitamin K, anti-vitamin K that we use in Europe. And then he was sent to cardiac rehab for smoke cessation counseling and to hematology to do the thrombophilia workup. So for this kind of test, we have to wait 3 months until after an event to assess if the patient has any kind of thrombophilia. And these were the results of the thrombophilia test after 3 months, doing a 2-week bridge with low molecular weight heparin. To sum up, the protein S is normal. In brackets, we can see the normal values. But we found that he had both anticardiolipin and anti-beta-2 glycoprotein antibodies positive. So at this moment, what we could say, based on the criteria for APS syndrome, is that it's not ruled out because you need to have 1 clinical thrombosis plus 2 determinations of any of the antibodies separated by 12 weeks. So after 12 weeks, they repeated the test, and then we see the beta-2 glycoprotein. It's very high. The threshold is 7 to 10 is the gray area, and then more than 10 is very high. So we had a APS syndrome. So the key learnings from this case is that non-occlusive STEMI can be managed conservatively when PCI is not strictly required. Then in young patients without major cardiovascular risk factors that have an unexplained thrombosis, thrombophilia screening might be interesting because it might impact the decisions whether to anticoagulate or not. Now this patient is going to be on anticoagulation lifelong. And then, as always, an structured follow-up plan ensures safe the treatment, the escalation, and can confirm thrombus resolution, repeating the imaging.
Thank you for presenting that case. It's very interesting and helpful. We see these Minoka cases not infrequently, and to go through a nice comprehensive management like that is very helpful for those of us who encounter these. So just a couple questions. You performed your OCT of the LAD specifically. Was there something that drew you to that vessel, or did you actually image all 3 vessels and then discover this in the LAD?
So I was not the interventionalist, but when I talked to them, they started for the LAD because it's the one that I had engaged at that moment. And since they found that, they didn't OCT the rest of the arteries.
Thank you. I'd like to just ask our panel some thoughts. So maybe I'll start with Dr. Ioma. In cases like this with Minoka, are you doing routine intravascular imaging of all 3 vessels, or do you pause and do more an initial MRI to try to localize the event, or what's your approach in these cases?
So our center has a very strong MRI program. So once they're off the table and we now say this is a diagnosis of Minoka, we start with a CMR and then work our way down. And we actually had 2 cases in my service last week, so our residents were happy.
Any panelists who would have placed a stent in this case, or any comments on the treatment approach?
And I think, just highlighting the importance of imaging is very important. I mean, it got to us to the diagnosis, but more importantly, not only avoid the stent, but take the patient through the journey of diagnosing antiphospholipid and eventually, potentially preventing future events through therapy and all that. But I think, workup of these patients is somewhat difficult and variable between centers depending on resources, from non-invasive MRI, which we actually do. We love that approach, to if OCT is readily available, although less than 15% of all imaging being done in the US out of the 30% is 15% OCT, and it requires a skill set. So more basically, your case basically says and tells everyone that, hey, if you have OCT, be aware of how to use it, how to understand the images, because it can be very enlightening.
I'm going to make one comment. It's a great case presentation, but I'm going to get old-fashioned here and think with Minoka, or with a case like this, the thing that you don't want to miss in the cath lab is an occluded branch. The best way for you to figure out if you've missed it, 2 things. 1, get a colleague to come and look at the angiogram with you, but the second is to do an LV angiogram, not an echo, not an MRI, which is great for later on, but a left ventricular angiogram. And if you see that lateral wall is out, you're going to focus your eyes on that missed branch. Just as for the fellows out there, my personal bias. Okay, fantastic case. I think we should move on. Well done. Thank you. So we're going to move things around a little bit. There was a case that wasn't able to be presented this morning that's going to be presented now. It's a balloon with a mind of its own, Dr. Dutta.
Hello. Hello, everyone. Thank you. This was a case of no disclosures. So this is a 74-year-old lady, standard risk factors of diabetes, hypertension, previous stroke. She presented to the Rapid Access Chest Pain Clinic with CCS 2 to 3 angina. She had some inferior inversion on an ECG and a normal echocardiogram. Based on the fact that she was very likely to have coronary artery disease, the attending who saw her decided to go to an angiogram directly. So I'll show the pictures of the angiogram. So basically, she had severe 2-vessel calcific disease in the LAD and the right. Once we took these pictures on that day, we stopped, and she went for a heart team discussion. The other reason to stop was she forgot to stop her anticoagulation, so we were not ready to take on a complex PCI without any discussion. So she was discussed in the heart team, and she was a surgical turndown because of frailty, previous stroke, and the poor physical reserve. So she was brought in as an elective procedure. We decided to do the LAD first, and we thought that we would need rotablation. So we did rotablation with a 125 and a 15 burr. Everything was okay. We then did an IVUS. We took a 2.5 and a 3.0 balloon, and on the IVUS there was still some calcium, so we took a scoring balloon. And after that, we took a 3.5 NC balloon and then stented the LAD. Once we stented the LED, the picture after we have done the stent, there was some haziness on the proximal edge of the stent. So we did repeated an IVUS, and the IVUS actually confirmed that there was a proximal edge dissection. Sorry, it's going, I don't know why it's keep on going forward. So because it showed that there was a proximal edge dissection, we decided that we would do a left main to LED provisional stenting. So if we took the diagonal wire out, we wired the circumflex, and we stented LED to left main. Everything went still pretty well. I was feeling very happy because it was one of the first cases I was doing root ablation on my own. We then did a kissing balloon inflation, did a final IVUS run, which showed that the proximal LED and the left main needed further post-dilation with a 4.5 and a 5.0 NC. So we took a 4.5 NC to the LED, and we took a 5.0 NC to the left main. Now, this is the 5.0 NC inflated to the left main, and this is the picture after I have come down on the deflator. So the balloon was still up. So within the next 10 seconds, the blood pressure went to 80, ST elevations everywhere, a lot of chest pain, me and her. Obviously, my attending came over. We did a gentle pull, emphasize on the word gentle, to see if it moves. And obviously what we don't want to happen happened, and the hypotube broke. So now we have a balloon with a bit of hypotube in the guide, but we don't have any way to control it. So what we decided is we still had that wire in the circumflex, and when we took the fractured balloon out, we knew that a part of it is in the guide. So we put a 3.0 balloon on the other wire, on the circumflex wire, in the guide, used it as a trapping balloon to trap the fractured hypotube of the other balloon, and then gently pulled the whole thing back. So now we had a bit of control. She was a bit more stable. ECGs were settling. Blood pressure was okay. She needed 200 micrograms of phenylephrine, but now we were in a conundrum of what to do now because that balloon was still semi-deflated. So what we initially tried to do is we tried to gently pull it back because we still have with the trapping balloon to see if it would come out. And it did come to the proximal forearm, but wouldn't go beyond that, and the patient had severe pain in our forearm when we tried to pull it any further. The thing that we had with our gentle pull before, we didn't want to do another gentle pull. So we actually pushed it back to the aorta. The picture should work. Yeah, so that one is us pulling back, and this one is pulling, pushed it back into the aorta. We decided we'll take a second access so we took a 7 French femoral access, took a end snare through there. We managed to grab the balloon, grabbed it multiple times, trying to see whether if we grabbed it multiple times, would it deflate, but it still became semi-deflated. There was a thought whether we could take a stiff wire, like a Hornet or a CP12, but I think by that time the balloon was hanging in the aorta, so in that 3D structure, we didn't know where the wire was going. We didn't want to do anything. So finally, we decided that we have to take this whole thing out. We initially tried, but that semi-deflated wouldn't even come out through a 7 French sheet, so we actually took the whole thing out together with manual compression of the groin. The groin was otherwise fine. There was a very small hematoma, but no obvious problem. She was admitted overnight, no further complications. She was monitored 48 hours and was discharged. And she was still happy to come back for the right coronary artery root ablation even after this. The learning points that we thought that we were thinking, why would that happen? So the 3 possible mechanisms was, one, there could be, when we are doing it on a severe calcified lesion, the balloon might recoil sometime and compress the balloon entry port. So the way we work on an indeflator, we can inflate it, but the deflation doesn't work. The other is if the balloon is strangulated within the guiding catheter, or if I've pulled it before it was completely indeflated. And the third one is if there was damage in the balloon hypotube, which we didn't know, like a kink while we were putting it in, or a manufacturing defect. We did send it back to the manufacturer, and they came back and said the balloon was perfect. It was all us. So the learning points are strangulated balloons during PCI is a rare, but it's a serious complication. And I think, fortunately, had it as a fellow, so I now know what to do. Don't want to have it, though. The mechanisms I've already gone through. And I think the idea of the trapping balloon was something that was a very good teaching point for me for the case. Thank you.
That's a fantastic case. What a nightmare spot to have a balloon not deflate. Hey, so definitely, I think it's important too to think in that moment when the patient was crashing somewhat. You know, if it wasn't going to be promptly resolved, what was your next backup plan in terms of hemodynamic support and surgery and things like that?
Yeah, we already called. We didn't have on-site cardiac surgery with this on this center. But when we had in the forearm, we called vascular surgery to see whether they would help. They pretty much peeked and said there's no options and went away. When I was preparing this presentation, there was one thing we could have done. There's a case report. Is when it was in the forearm, we could have tried to puncture it with a needle.
Yes, I was just about to mention that case actually. So yeah, so when you get it down to the forearm, radiographically, you can puncture it under fluoro with a sharp needle. I think it was a Canadian gentleman that presented that. I saw his case before.
Fantastic save. Fantastic save. Really nice case presentation. And we'll just ask others to comment. I just want to make one comment. When you see this, people talk about the back end of a coronary wire to puncture it. I would encourage the fellows to try and do that on the bench. It is really hard to puncture these wires. Hence that needle case that was presented, I think, is something you should bear in mind. It's a nice option for the arm. The only other comment really is for when you're snaring, when things have gone south and you want to snare, is always, I think, use a bigger sheath than you think you're going to need.
In retrospect, I thought we should have gone to an 8 or a 9 inch.
Yeah, and a long sheath as well, because you can do an awful lot in the abdominal aorta that you can't do in the external iliac when you're pulling stuff through. But that was a fantastic save. I'm sure the patient's very lucky. Comments from colleagues?
From that standpoint, with regards to externalizing devices that have been lost, there's a specific device or purpose-built sheath called the ONO, appropriately, I guess, the ONO sheath that funnels at the end to catch things, pulls it in, and then we'll retract it in. It's used a lot in structural, so if that's available, that's an option as well.
That's the 14 French, though. So we're talking big stuff, right?
It's
14
big.
French to deliver the basket. So it's a great option, but
last resort from that standpoint, if you couldn't get it out. And then the other thing, too, as you're pushing the balloon back in from the arm into the aorta, don't ask me how I know this, but be cautious because you can cause a type A dissection doing that, re-advancing gear without wire ahead of it in that situation. So just if there's any resistance, don't push.
Yeah, I think to Dr. Gulati's point, groin is your friend, going femoral axis and given a bigger size sheath, and long is good. So I know you said groin is dirty, but femoral can be your friend.
Groin is still necessary.
And for fellows, no matter how early, mid, or even late career, whenever you have this and you have an operator in the lab, just ask for an extra set of hands. It's always helpful because you're so worried about the patient, but at the same time, you're trying to think through the process of how you can retrieve this and get the patient through this. So always ask for a second pair of hands.
One of the cheap trick, which has worked a couple of times. This is a terrible complication to have because you just can't see this coming. You're doing a fancy rota work, and then the last thing in the world you expect is a balloon entrapment. Is to actually take a syringe and do a manual negative. I've had a couple of cases. Did you guys try that at all in this case?
No, we tried on the indiflator a few times, but it didn't do anything. But yeah, remember that.
But I think your key move was, staying calm and then trapping it. If you didn't trap that hypo tube and let's say you just pulled the guide and you lost it, that would have been disastrous. So I think the take-home point for this is the idea that if you lose the integrity, trapping that was key.
A fantastic save. Congratulations, a great presentation. So the next case is, we're moving around, is Victoria Odeleye, who's going to present a case of progressive postpartum dissection. Victoria.
Hi everyone, my name is Victoria. I'm a second-year fellow at University of Tennessee, Nashville, affiliated with Ascension St. Thomas Hospital. And I had the opportunity to encounter this case during my consult month as a first-year fellow. I do not have any disclosures. So this is a 35-year-old postpartum female who presented with chest pain after 1 week of delivery. Pertinent cardiovascular history, she has no history of coronary disease or cardiovascular risk factors. Previously healthy, uncomplicated pregnancy, no gestational hypertension or preeclampsia. So she did present with some dynamic EKG changes with T-wave inversions and lateral leads and elevated troponins, which downtrended, but just given her presentation and her history, there were some concerns of possible SCAD in this case. So we did take her to the cath lab. And when we took her to the cath lab, we did see that she did have SCAD. In the left main, she had also had some findings in the LAD and diagonal as well. So given she was fairly stable, she also had a very long dissection in the proximal to mid RCA. So given she was fairly stable and there's really no, I think, solid management for patients with SCAD. I think treatment is kind of controversial because she was fairly stable and the risk of putting a PCI in this was concerning for propagation of her dissection. So we kind of treated her with conservative management, which she did do well. So she was on aspirin, some calcium channel blocker, beta blocker, and nitroglycerin. So we did discharge her from the hospital after about 2 days. But 3 days post-discharge, she represented with chest pain. At the time, she presented to our sister facility with chest pain, and she had ST elevations in her inferior wall, inferior leads. Initially, she got nitroglycerin, and the ST elevations actually resolved. So there was, maybe some hypothesis regarding maybe this was vasospasm, but she got multiple doses of nitroglycerin, but then her chest pain wasn't getting any better. So we consulted our sister hospital that had interventional and CT surgery available, and we had transferred her over there, and she was taken immediately to the cath lab. So when she got to the cath lab, she did have progression of her SCAD in the LAD and also RCA extending into the proximal PDA and PLA. She did arrest on the CAT table as well, but she just briefly had CPR with reservation of ROSC. So luckily for her, we had already prepped the OR in this case. So the OR was already ready for her to go, and she ended up getting a multi-vessel bypass surgery. So the clinical challenge in this case was we had this patient with multiple vessel SCAD, initially hemodynamically stable, and then discharged home, and then came back with chest pain, ST elevations, and then she became hemodynamically unstable with left main involvement and then VF arrest, needing urgent revascularization. So after she had underwent the cabbage, the surgeon said her vessels were actually very fragile, and if a PCI would have been done in this case, it would have probably been catastrophic, probably caused perforation or propagation of her dissection. So the decision was to proceed with a cabbage, which was the right decision in this situation. So she did get only vein grafts. She got a vein graft to the LAD, diagonal, OM, and PDA. And the reason for this was, because SCAD patients, they do have spontaneous healing of their coronary arterial walls eventually, and just to kind of prevent failure of very good Lima graft once she eventually heals. So the decision was to do a vein graft in that situation. Intraoperatively, the surgeons, they say she did have extensive dissections involving the left main LAD RCA with very fragile vessels. She did recover well. Post-op was uneventful. She was discharged on day 5. So the key learning point in this case, I think SCAD is one of those situations where it's kind of sensitive and nobody really knows exactly what to do with it. And I think there's a couple of papers out right now, and I know the current guidelines is just based on observational studies and expert consensus, but they're actually evolving papers now in regards to left main SCAD with left main involvement, and it's been shown that revascularization is superior to conservative management, irrespective of the patient's hemodynamics in this case. And PCI is also often limited in SCAD due to vessel fragility and risk of iatrogenic extension as well. Thank you.
Thank you for a great presentation. A comment and a question. The comment is that there's a 15% risk of early extension of dissection in conservatively treated patients. 3 predictors, and this patient had 2 of them,
Yes.
was multivessel
2
involvement.
vessels,
Had 2 predictors, multivessel involvement and intramural hematoma only, absence of. So she was at high risk for extension the first 5 to 7 days, but she was dismissed on day 2. So that would be a critique I would have, and the decision to send her home when there was a high risk that this was going to happen. But the question is, why not just fix the right with a lab? Why not just balloon that right was the culprit and let the left side heal? Was that part of your discussion?
So, so the plan was we could have fixed the RCA, but then the plan was also extension of the LAD as well. So that's why they also decided to bypass the LAD, because the LAD did progress.
Any further comments from our panel?
And I think Dr. Galati brought another point again that everyone should remember, that there's always a risk of progression in these patients, so we don't want to send them home early. I remember I had a patient when I was working with Dr. Galati, and I sent the patient home early. And I called, and the patient came back a couple of days back with recurrence of her SCAD. So once again, key point, always remember these patients are high risk. Keep them in the hospital for a couple of days and watch them. There are 2 papers. There's a paper I want to make sure that everyone in the audience remembers. There's a scientific statement that AHA put out on SCAD. So if you have a few moments, take a look at it and read it. The key teaching points there for everyone. And I think show the angiogram so people can look and see the SCAD features on the angiogram. And Dr. Glad, do you want to show people?
It's not working. I mean, this was an M&M case for our institution as well, so everybody got to learn from this. Thank you.
Yeah.
I'm curious, do you happen to have any CTA post-cabbage at all?
Yes, so she actually came back a couple weeks later with chest pain, kind of got everybody nervous, and then we did a CCTA, and her grafts were still preserved.
And that was a question as well, as for these patients, especially you have a relatively low risk patient. They have a troponin that peaks and comes back down. Potentially a non-invasive evaluation initially with CTA would have been a benefit, both to define the etiology and then also to risk stratify the patient. And then we always worry about the risk of extension of dissection. And one of the pictures, I know we can't advance to it, looks like there's some staining of the left main with one of the injections, and somebody pulls out relatively quickly. And then again, I know I said groins are gross, but again, a conversation about radial versus femoral for patients with presumed SCAD, and also a fragility of vessels and being cautious with deep engagement.
I just got a comment there. So I would disagree with both of those. I think we've learned, and there's now good published data from our place and others, that CT will miss a bunch of SCAD. So if you want to make a diagnosis in the current era of CT, you should do a coronary angiogram invasively. In the next year with the photon detection, I think that's going to be the way to go. And the radial, I admit I was a co-author on that paper that said like 10 years ago, be careful of radial. I think it's more technique and coaxiality. And you're a radial, yeah, exactly. So I think I would wish I could delete that paragraph from that old statement. So please ignore it now. Thank you.
It is worth mentioning, though, that most of these SCADs managed conservatively do well. I mean, I think we have majority of patients who don't have ongoing chest pain or in the throes of a STEMI are better left managed conservatively, and those patients who come back, it's amazing how they heal up. But I do think sending them home is dangerous. And also, you talk to surgeons, they do not like to bypass dissected arteries either. And so I think that this is a unique case.
Thank you.
Thank you. Okay, we're now going to welcome the LAD masquerade case back to the podium, please.
We're here. So my name is Maruf Sarwar. I'm a third-year resident, internal medicine resident at White River Medical Center. I am presenting this LAD masquerade. So we have a 64-year-old male with coronary artery disease status post-proximal LAD stent placed in 2019 at an outside hospital, presenting with NSTEMI. He had prior in-stent restenosis, treated with balloon angioplasty about 4 months prior to admission. Past medical history includes heart failure, mildly reduced ejection fraction with unchanged EF, atrial fibrillation on Eliquis. Troponin on admission was 1,090, and EKG showed lateral ST wave changes. He was taken to the cath lab where we obtained right radial access using a 6 French sheath. Here we engaged the left coronary artery with the JL35. The spider view showed severe 95% in-stent restenosis in the proximal LAD. This vessel gave rise to both diagonal and septal branches, and you can see that the mid-LAD was difficult to visualize on this initial LAO caudal shot. We suspected significant disease in the mid-LAD, but poor filling made it hard to confirm. This was likely due to the proximal stent limiting contrast opacification, making it tough to assess in multiple views. In this LAO cranial shot, we finally saw partial filling of the mid-LAD with about 80% disease and some mild distal disease. We actually later confirmed this after switching to an EBU guide and taking additional shots before any further treatment. As we continued the diagnostic angiogram, the RCA was engaged with the JR4. The RCA was a dominant vessel with about 30% disease throughout the proximal, mid, and distal segments. The PD and PL only had mild disease, so nothing here would explain the clinical presentation, so we went back to the LAD. We exchanged for an EBU 3.5 and wired the LAD with a run-through. It was tough getting through this in-stent restenosis segment. And we couldn't actually clearly visualize the mid or distal segments. That said, the wire did track smoothly along the expected course of the LAD and reached what we believe to be the mid to distal segment without issue. We actually attempted IVUS here, but couldn't cross the diseased stent, so we proceeded to balloon the proximal LAD with a 2.5 NC balloon in the ISR segment. Shortly after ballooning, we noticed a frank contrast leak, possibly from ballooning on our multiple IVUS attempts. We went ahead and advanced the 2.5 balloon to the tamponade, to tamponade the area. And at this point, we had to pause and reassess, including whether we were actually in the true LAD. And what you see here is Frank Ellis Class 3 perforation, and that's my best attempt at a cartoon drawing. Crayola, please sponsor me. This image shows the 2.5 balloon in place for tamponade. Shortly, the patient's blood pressure dropped to 70s over 50s. So given the concern for cardiac tamponade, we actually performed a bedside echo which showed no clear pericardial effusion. However, early tamponade physiology couldn't be ruled out. So we initiated the patient on pressor support with epinephrine. And in light of this, we actually obtained right femoral access in case we needed to escalate support, including the possibility of an impella. We started with 4 French, and if needed, we were going to upsize to a 14 French for impella CP. Our initial plan was to place a covered stent, but IVUS still couldn't cross, so we weren't able to fully assess the perforation. We switched to a steeper areocranial view, noting a better view of the septals and diagonals, and shifted to the ping-pong technique. Our thought was to use 2 guide catheters, which you can see in the picture, to maintain hemostasis while preparing and delivering definitive therapy, all without losing wire position. And in our case, this could mitigate the risk for further bleeding. We took an even steeper areocranial view, which you can see above, which better laid out the diagonal and septal branches. With better visualization of the apex, it became clear that our initial wire was likely in a large septal. Using the second guide from our ping-pong setup, we rewired with a run-through and found what initially looked like a diagonal branch was actually the LAD heading to the apex. And we actually were able to confirm this with IVUS, and we were actually in the true LAD. This video illustrates our ping-pong technique. While tamponading the septal perforation, we delivered a 3.0 NC balloon and quickly pre-dilated the mid-LAD and were able to restore more flow in the true vessel. This areocaudal view confirmed persistent septal perforation despite multiple tamponade. Given the prolonged leak, we were concerned about left ventricular outflow tract obstruction from a septal hematoma. And formal echo showed no effusion and preserved EF, so we moved forward with a coiling strategy. And just to highlight here, as you can see, even though the perforation remains, we now have a wire down the true LAD with TIMI 3 flow to the apex, so ping-pong technique was at least partially successful. We delivered the coil using a trapper balloon to trap the short wire, then advancing the penumbra microcatheter into the septal branch to deploy the packing coils. This successfully sealed the perforation and resolved the septal leak. After coiling, we removed the radial guide and pre-dilated the proximal to mid-LAD with a 4O and C balloon in the previously stented segment. IVUS and angiography showed disease extending beyond the proximal edge of the prior stent, so we actually had to extend coverage further back into the proximal LAD. We placed a 4-5 stent proximally and a 3-5 stent in the mid-LAD, fully covering the prior stent. So we post-dilated the proximal LAD up to 5 millimeters with excellent expansion, no dissection or perforation. And here's our final angiogram, which showed TIMI3 flow with full revascularization down to the apex. The major septal remained patent, and there was no further leak. Patient left the lab hemodynamically stable, off pressor support, and without chest pain. On follow-up, patient had no angina and remained NYHA class 1, class 2, doing well clinically. So just some learning points. A large septal can mimic the anatomy and curvature of the LAD, especially without a clear view of the apex, since miswiring is a real risk. Steep areocranial shots are sometimes essential. Septal perforation can lead to serious complications like LVOT obstruction, so early recognition is critical. So you have a low threshold to obtain an echo, and advanced methods like ping pong technique and coil embolization can serve as effective bailout strategies, and most importantly, stay calm, reassess, and adapt. Thank you. No disclosures.
Yeah, I mean, great case. Obviously, you know, I would just highlight that imaging can be very helpful. Obviously, as you highlighted here, these twin LED systems / septal that runs parallel to the LED can be very deceiving. I would just one comment about septal hematoma management, bringing back some horrific memories from a case I will never forget. These can be very difficult, because what happens next is that all the septal perforators start bleeding into the hematoma itself. And you can put covered stents to try to seal the septal hematomas, but they continue. So the only way to do it, and as you've highlighted, they can't obstruct the LVOT. They actually pretty much freeze the septum altogether, and the patient can go into cardiogenic shock. So one way to handle it is actually you can perforate the septal hematoma. I wouldn't advise that as a routine practice, but perforate the hematoma into the RV on an LAO cranium with a stiff wire in order to evacuate that. And that would potentially help it. Otherwise, surgery, obviously, if the patient is a surgical candidate.
So on retrospect, I was in the case doing this while Dr. Anantha was actually doing the case. And one question I asked is why he didn't deliver the covered stent. And I believe it's because he wasn't confident in visualizing the perforation with IVUS, and I believe also he didn't have enough outflow, I think, so he just decided to ping pong. And
yeah, that was a great call, actually, because just thinking about the stent going up into that septal, it would have probably made things worse. Yeah.
I was just going to say the same thing. I'm glad you didn't put a covered stent, actually, because you have that other giant septal branch there. If you had ended up going across that and lost it, I think the patient would have got sicker for sure. So the coil was a good choice.
Again, a fantastic lesson for us all. I think a really valuable presentation. Did you shoot the right at the end to see if there was retrograde septal?
You know,
filling?
Interestingly, this patient was actually, he's actually my internal medicine clinic patient, grossly non-compliant. And he was actually admitted, I think, last week with chest pain. And we did shoot the right, and everything was open. So. Thank you. Internal medicine resident.
Thank you very much. Okay, we're going to move on to try again to cross. Ivan Pena.
So I'm Ivan Pena. I'm based out of Louisville. No disclosures. So our patient's a 79-year-old man with the usual suspects, so hypertension, hyperlipidemia, diabetes, and he's had multiple admissions for pulmonary edema and volume overload. And his outpatient cardiologist, or his primary cardiologist, thought that he heard like a louder systolic murmur than what he was used to, was concerned for worsening MR, and he was set up for a TEE. So the TEE actually only showed mild MR with a preserved DF. Stress test showed, which he was also doing thinking maybe there was ischemia that was causing heart failure, showed a mild hyperkinesis of the inferior wall and a moderate-sized infarct in the inferior wall with some ischemia. So he set him up for cath. And you can see a dominant circ. You know, the left main looks pretty normal, calcified but normal. LED has some mild disease in the proximal segment, and some moderate disease that you'll see in the areocranial in the mid segment. But the dominant circ right in the prox segment has a 95% stenosis, and there's also a subtotal small OM right where the stenosis is. Here you see some mild LED disease, another picture of the circ, and the RCA was non-dominant. So his thought, given that the patient had now, I think, like 3 recurrent admissions with heart failure and volume overload, was he was having ischemic MR, and he thought, if I fix this vessel, maybe I'll prevent all of these admissions. So he tried multiple wires. His workhorse is a beamer. So he tried a beamer, a fielder, a whisper, a pilot. You can see there that he does have a microcatheter for support, but he was unable to cross. And the patient has like a baseline creatinine in the 2s. He had used a lot of contrast, so he decided to stop and send him to me. So at this point, it's a wire uncrossable lesion. So what can you do? So I'm assuming well, I know he did a couple of these things, but I'm assuming he put different bends. He definitely used different wires. He used a microcatheter for support. So the next things would be ADR or retrograde, and here retrograde is not available because there's no left-to-left collaterals and the right's non-dominant. So I came into it thinking, okay, well, we're gonna get a lot of support. So I went in with 7 French EBU, 7 French guideliner up front, put the Cyan Blue, which is my workhorse, into Turnpike LP. And it took that little bend and it just flew right in. So, you know, sometimes it's better to be lucky than good, which we say all the time. Except that was the start of what ended up being like a 3-hour case. So, can I go back? So I tried to deliver a 1.5 Takeru balloon. Usually I try to test the lesion with a microcatheter, and I couldn't torque this Turnpike LP through. And usually I do that, one, to see how the lesion will behave, but sometimes I think it'll create like a little microchannel that maybe the balloon can take. In this case, it would not go. So I tried a 1.5 Takeru, and you can see that the guide and the guideliner are basically getting pushed back, and that would not cross. So we went from a wire uncrossable that I was pretty lucky that the wire kind of just went through into now a balloon and microcatheter uncrossable lesion. So I tried granuloplasty with that 1.5 Takeru that I had and just blew it up. And then this is an image of a second Takeru, and again you can see, one, you can't even see my guide from how much I'm trying to push, and the guideliner's kind of not even engaged in the left main. So a new 1.5 after granuloplasty still would not cross. Now here you can already see I did laser, but at this point the options were either trying to free throw a rotafloppy, so wedging in a microcatheter into the lesion and seeing if I could get a rota in, or ADR and not even use the wire that I have, or laser. Now the reason why I didn't do the microcatheter rota is he already had so much trouble wiring, and I thought I didn't want to push my luck since that wire flew in the beginning. So I decided to go with laser. So I went with a 0.9 laser, 80-80, and eventually, I mean very slow, but eventually it kind of went. And here you can still see the laser is struggling. You can see as I push, the guide's kind of backing out and the guideliner's backing out. So then after the laser went through, I tried to deliver a 1-2 balloon, and that would not cross. You can see again, I promised the guide was always engaged well whenever I started these. But by this point, it's not, right? So even the 1-2 balloon after going through with laser would not cross. So I decided to just re-engage everything well and try the microcatheter again, and was able to switch out for a rotafloppy. And after a couple of rotational atherectomy runs, we were finally able to get through. I don't know if I need to play the whole thing, but you know, Ivis showed in the distal reference was about 3.5 to 4. You can see at some point very eccentric calcium that then becomes very focal and concentric at the lesion. But at this point, I was able to deliver a 3.5 NC that expanded pretty well, and then covered the lesion with a 3.5/48 stent, did a 4.0 post-still, and the stent was pretty well expanded in that pose throughout. And this was about 6 months ago. He hasn't had any further admissions, so I think we did the right thing. But I think this was a good case to show, you know, wire and balloon uncrossable lesion. So, you know, there's this algorithm out there. You know, if you have a balloon uncrossable lesion, obviously first try a small balloon. You can try granuloplasty because you don't need a special wire for that. You can increase your support, which I did up front. If that doesn't work, I've never done wire cutting, but that is an option if you're able to somehow get a second wire. In this case, it was hard to get one wire. And then laser, which I have used a couple of times in lesions like this. That's the only reason why we still have the laser in our lab. But in this case, I think it softened it enough that it allowed me to get the microcatheter through and then do rotational atherectomy. Yeah, that's my case.
So excellent presentation. I don't have a lot of comments about your approach and technique because I think you went very thoughtfully through that gear won't go algorithm. Essentially, you tried all the things and really nice demonstration of working your way through that systematically. One comment I would make with your wiring, great job there. I think to some degree that was predictable based on like the way that you would see their wire course on that initial angiogram. So studying the lesion very carefully can be helpful. I think they were wiring superiorly into a suboptimal tract, and you kind of took that inferior tract and your wire got across. So just keep that in mind with difficult wiring cases. Any thoughts from the panel?
No, I think laser is underutilized in a lot of different ways, and the great case and an example there, often once the laser crosses, even if the balloon doesn't, a torquable microcatheter can be spun through and then swapping out for more aggressive atherectomy, which you did. Overall, you know, a good result, and glad you're able to solve it for the patient and for the benefit of their MR.
Actually, one other point, if you were able to get a microcatheter across earlier, if you can get a wiggle wire down, once in a while it's a good secret weapon, and it just takes a different angle and gets you away from spicules of calcium, allows your gear to get down, at least your smaller balloons.
I feel like every time I use a wiggle, the case becomes way easier. We had a fellow that said wiggles for life, so yeah.
I think my staff knows that if you open a microcatheter, just bring a 190 wiggle. We're going to exchange for that and trap out the micro later.
Thank you.
I think that's fantastic. If we could just have a round of applause for all of the speakers, and thanks to the AV pair at the back for fixing everything at the end. I'm glad we got everything done. So I think we can maybe break. We'll have the panelists stay here and do their voting. And they are open to bribery, just so you know that. Okay.